I'm going to also acknowledge my colleague Nathan Ford in the WHO headquarters. The slides are mostly his, and I'm kind of presenting on his behalf. I'm going to talk about the public health approach to reducing the burden of advanced HIV disease and introduce you the quite kind of new guidelines on WHO recommendations. Have to say that the public health approach is not only for the developing world. It's about, the public health approach is having an approach that treats the most patients within the resource constraint that we all have, irrespective of your income status in that country, because we all have resource limitations, whatever income status of the country. The background of these recommendations is that there is a significant proportion of patients that continue to present with advanced HIV disease. We all know that people starting ART with advanced HIV disease have death, particularly in the first 6 months following ART initiation. The major cause of death, very well covered by Kumar and Dr. Lee, TB, bacteria, cryptococcal meningitis. The WHO guidelines include individual recommendations for diagnosis, prophylaxis, and treatment. And there are also very recent studies that have assessed the potential for an enhanced package of interventions to reduce mortality and morbidity. And we are all familiar with the patient with very, very severe HIV disease. So why are people still dying from HIV? Our numbers on ART has grown tremendously over the last decades. But the numbers of death has not really reduced a lot. And it really varies between countries. So the WHO definition of advanced HIV disease, I'm sure you know that, being treating clinicians, is that for adults and adolescents and children older than 5 years old, advanced HIV disease is defined as CD4 less than 200 or WHO stage 3 or 4. It includes both ART naive individuals and those who have started, stopped, and come back again. So any child, any children that is younger than 5 years old with HIV is considered to have advanced HIV disease. In 2015, based on the almost a million adults from 55 countries, an analysis from the IDEA Cohere cohort, we saw that 37% of countries of people starting ART did so at CD4 count less than 200. So that's quite substantial. This is our persistent challenge of advanced HIV disease. In South Africa, 37% start treatment at very low CD4 count. And the analysis showed 46 countries. In 46 countries, 1/3 of people started ART with very low CD4 count. So we really do have a challenge. And this is still our challenge over the last decades. Now, how about the causes of mortality? My colleague Nathan Ford did a systematic review. And we actually saw that in adults, we still have issues of TB, toxoplasmosis, crypto, PCP, and pneumonias. And in children, TB, PCP, and bacterial infections and bacteremias. So it's quite similar across almost all countries in the world. Now, we need to target the right OI. Whatever intervention, we need to target the right OI in order to prevent morbidity and the mortality that comes. In this analysis by Osler, we saw that the temporal trend in cryptococcal cases is more or less stable, although we can see that in the bottom black line that coverage has increased. Now, there has been recent studies on the package of intervention for reducing mortality among patients with advanced HIV disease. It's called the Reality, Enhanced Prophylaxis on the left, and the REMSTART on the right. The Reality studies looked at countries like Kenya, Malawi, Uganda, Zimbabwe. And in REMSTART, they look at Tanzania and Zambia. Each of them were open label, big studies, and they both look at populations where the CD4s were really low. The main outcome was pretty similar, mortality reduction at 6 and 12 months. In the REMSTART, you had rapid ART initiation, and you had screening tests and adherence support. While in the other Reality study, you had cotrimoxazole isoniazid, B6 daily, fluconazole, so pretty similar in some sense, except for the REMSTART. What did we see? In both studies, they found about 28 or slightly less than a third reduced death. Reduction in incident or morbidity, reductions in hospitalization, and in one of the studies, improved adherence at 6 months to treatment. So we looked at basically the benefits and the harm of these kind of packages. The benefits of having an enhanced intervention is the reduce all-cause mortality, reduction of incident morbidity, reduced new cases of TB and cryptococcal disease, reduce new hospitalizations, and really, for us in the WHO, trying to make things simpler, because complicated doesn't really make things happen at the ground level. So the simpler the package, the better it is. And it's consistent with the public health approach. And it promotes increased attention to the advanced disease. The harms of potentially giving this kind of early interventions is the potential for AMR, antimicrobial resistance, especially to azithromycin, and the potential for antifungal resistance, like fluconazole, and of cost to health services because it's about increasing use of drugs. And the simplified package may reduce attention to other important comorbidities or other infections. So in the new WHO recommendation, we recommend that a package of intervention includes screening, treatment, and/or prophylaxis for major opportunistic infections, rapid ART initiation, and intensified adherence support should be offered to everyone presenting with advanced HIV disease. This is strong recommendations based on the recent studies. And in the WHO recommendations, in this table, we have components of what the package of care is for people with advanced HIV disease, spelling out basically what in diagnosis the intervention is, and what the considerations are when you look at CD4 count, adults, adolescents, or children. And we look at prophylaxis, what kind of prophylaxis that should be used, and when should it be used. And for ART initiation, as well as adapted or intensified adherence support. So this is a little bit more about it. For package of care for people with advanced HIV disease, for the diagnosis with the expert as the first test for TB, what the prophylaxis should be, and for ART initiation, what kind of initiation, rapid initiation, and adaptation of the adherence support. Now, it's very interesting because this is quite new. It's about the development of better drugs or new drugs that is combined, which is a scored fixed-dose combinations. And you can see from the picture that these exist, and you can break the tablet and use the half dose if, for children that are less than 12 years old. And this now exists. The guidelines also look, there is a guideline on cryptococcal disease that talks about diagnosis, prevention and screening, and for treatment, as well as the timing for ART. Generally, the studies have shown that shorter induction treatment provides you better outcomes. Now, there are several considerations when we are doing these in these guidelines. When you have presumptive treatment in managing TB, pneumocystis jirovecii pneumonia, severe bacterial infections, and cryptococcal disease, it should be considered in settings where access to diagnosis is limited and people present with typical signs and symptoms, especially when accompanied by clinical signs indicating severe illness. The algorithm for managing people with HIV who are suspected of having TB and are seriously ill incorporates presumptive treatment of TB, infections, and pneumonias into the care pathway. So where there is a very high clinical suspicion, there is presumptive as well, the consideration for presumptive treatment. There has been several guidelines on this, and we want to have a renewed focus on advanced HIV disease, because really a third of all patients that come through really will be at high risk of death. So it's something that we cannot ignore, and there's increasing experience and increasing attention is important. I would like to point out that in March of 2018, there is a special supplementary that looks into the advanced HIV disease late presentation, and you can click on this and look into it. I would like to acknowledge the very many people that have actually contributed to this guideline. Thank you.
Yeah, thank you, Po-Lin.